into the tissues. We also talked about addition, which is interplay between the ICAM, the BCAM, and their own integrin. We talked about transmigration, which is interaction between the PICAM. Then migration, when the white blood cells have gotten into the tissues, they've escaped the endothelial cells. They are now in the tissue. So the migration is now due to attraction from the chemotactic factors, which we listed: C5a, interleukin 8, LTB4, and the other ones. Then we talked about chronic inflammation to be a form of inflammation that um, is characterized by the mononuclear cell infiltration, which includes the macrophages, the lymphocytes, and the plasma cells. And we said any tissue or any organ that is undergoing chronic inflammation have simultaneous tissue destruction as well as tissue repair. And the repair usually comes in form of fibrosis, which is the reason why they come up with scar at the end. And we said majority of the stimulus for chronic inflammation are very persistent. Maybe there's a persistent infection that is very difficult to eradicate, like tuberculosis, like syphilis, like leprosy, or some fungi like histoplasma, or chronic viruses like hepatitis C and hepatitis B. They can all cause chronic inflammation of the particular tissue that they are infecting. And we said because of the fact that the T cells response to that can be a form of type 4 hypersensitivity. So if it's not persistent infection, it can be persistent foreign body like silica, like talc, like sutures, anything. If it's not that, it can be autoimmune disease because the antigen are self-antigens that are always in the body. And again, the pathology behind autoimmune disease is just elaboration of the T cells and the B cells against self-antigen. So the B cells, the T cells, they are mononuclear cells. So that is chronic inflammation. Then we talked about the fact that the macrophages are very, very important because they are the ones that will first activate those T cells before you can start the inflammatory process. So the macrophages can get activated in two forms: the classical pathway and the alternative pathway. So if the macrophages are activated in the classical pathway, they release pro-inflammatory cytokines that cause the tissue damage. If they are activated in the alternative route, they are going to start releasing cytokines that will help them initiate repair. So, and the repair is even bad because it's going to cause fibrosis, which will disfigure that tissue and impair the function of the organ at the end of the day. And we talked about the outcomes, which include scarring from the fibrosis. We said amyloidosis can occur, particularly secondary amyloidosis due to increased level of the serum amyloid A. Then we said it can also lead to cancer. So we said we gave an example of hepatitis C that causes chronic gastritis, which is a chronic inflammation, and from there it can lead to cirrhosis because of the regeneration, which is the attempt to regrow, and the attempt to repair, which is the scar. So you tend to notice that you find the regenerative nodules and the scar in the liver, and the recurrent, regeneration and scarring will allow the cells acquire mutation that will lead to malignancy. And we said about Helicobacter pylori infection can also cause malignancy from a background chronic inflammation because they hide within the stomach region. It's very difficult for the microbes for the immune cells to eradicate them. They will cause chronic inflammation of the gastric mucosa, which is chronic gastritis. That one can undergo a metaplastic change like intestinal metaplasia, which is a precursor for gastric adenocarcinoma. Then we talked about wound healing to involve three basic phases: um, inflammatory phase, proliferative phase, and remodeling. So for the inflammatory phase, we are looking at a wound that is fresh. The first thing that will happen is for the vessel to undergo vasospasm, activate the platelets so that they can secure hemostasis to arrest the bleeding. Then the next thing is the white blood cells to come around, activate the mast cells. The mast cells degranulate, release histamine. The other mast cells, the other white blood cells like macrophages, dendritic cells, they release other inflammatory markers like bradykinin, like serotonin, and all those things that will cause vasodilation so that more blood flow can happen and can have recruitment of more white blood cells. Then those interleukins that are released also activate the endothelial cells so that those white blood cells that have come around can escape into the tissues. So that's the inflammatory stage. The next thing is now initiating the repair, which is the proliferative phase. So you need to employ some specialized cells, and those cells include the fibroblasts. So the first thing is to activate the fibroblast. The macrophages will release fibroblast growth factor, transforming growth factor beta, the platelet derived growth factor, and the other ones, so that they can activate the fibroblast. And fibroblasts will now start depositing granulation tissue, gran substance that contains fibronectin, glycosaminoglycans, and alongside with those ones, they also deposit type 3 collagen. Then the next thing is for the vessels to grow into those matrix, that gran substance matrix, and that is due to the activity of the vascular endothelial growth factor, the fibrous growth factor, and the other ones. So you have recruitment of the endothelial cells into that ground substance, and they are the one that will now differentiate into the vessels. Then after the vessels, you now need to complete everything by epithelialization. You need to form a skin covering over that wound so that you can have a barrier between the wound and the external environment. So that is where the epithelial cells plays their own role. Then at the end of the day, you have to achieve contraction of that wound so that you can oppose the edges together so that the size of the wound will reduce. So that is when you need to differentiate the fibroblasts to myofibroblasts. That is fibroblasts that have acquired contractile protein and they can now contract. So the macrophages will also be there to remove the cellular debris that is remaining and also help dissolve the clot. So the major minerals or vitamins or elements that are important for the proliferative phase include vitamin C and copper, because we need vitamin C to hydroxylate our lysine and proline residues to form the type 3 collagen, and we also need copper to catalyze the activity of the lysyl oxidase that helps to cross-link those collagen. Then the final phase is remodeling, where you need to degrade your type 3 collagen to type 1 so that you can increase the tensile strength of that wound. And what you need to catalyze that degradation are the collagenases, which are metalloprotease enzymes, and they require the activity of zinc to function. So that is that about wound healing. Then we talked about chronic granulomatous inflammation. That granulomatous inflammation is a form of chronic inflammation.
So, Baba, please can you enlarge your screen a bit?
Okay, so chronic granulomatous inflammation is just
Thank you.
a you're welcome, Dr. Zulia, too. Granulomatous inflammation is just a form of chronic inflammation. So it's just chronic inflammation, but we are forming granulomas here. We are warning off that antigen, that stimulus that is um, triggering the inflammation because we cannot completely eradicate it or we cannot degrade it. So at the end of the day, what we have said about chronic inflammation will still be happening. You'll still be having activation of the macrophage in the classical pathway that they'll be trying to destroy that antigen, and in the process they're also going to destroy the healthy tissue, and some of them will also be activated through the alternative pathway in order to repair what we have been damaging by fibrosis, which will eventually lead to organ damage at the end of the day. So we said there are some typical stimuli that are responsible for triggering this granulomatous inflammation, like infection. So, microbacterial infection, both of them, Mycobacterium leprae that causes leprosy, Mycobacterium tuberculosis that causes tuberculosis. We talked about the catch scratch disease that causes stellate necrotizing granuloma. We talked about some other organisms like syphilis, tertiary syphilis particularly, and granulomatosis in septica for listeria and the other ones. Then we said if it's not infection, it can be non-infectious, maybe due to some immune-mediated disease like Crohn's disease, like sarcoidosis. We said it can also be, cause of vasculitis too. So vasculitis, there's no infection that is triggering that. So like someone that has granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis. So all those ones are going to make sense to us by the time we are doing um, musculoskeletal or is it renal now, one of them. So uh, it's going to make sense to us very well there. So then the third for the non-immune includes the foreign body, like someone that are taking silicon, talc, beryllium, and all those things. So they can also lead to formation of the granulomas because the body will try to wall them up because they cannot degrade them. So they have to form granulomas around them. And how are these? And we have two forms of these granulomas: the cystatin, the non-cystatin. We said the cystatin is the one that will have a central necrosis. That is, you'll be able to degrade the antigen. You'll be able to kill off the antigen and you have a central focus of dead tissue. That is cystatin necrosis. And you can only have that when the cause of the granuloma formation is a microbe that you can degrade. But if it's like a foreign body, you cannot degrade it. You cannot form any central necrosis. So it will be non-cystating. So, or for all these non-infectious causes like sarcoidosis, growth disease that we mentioned yesterday that we don't even know the antigen, you don't find any central necrosis. But for infectious origin like tuberculosis, fungal, viruses, and those things that triggers cystating, sorry, we don't have any virus that triggers central nucleus, but more of the bacterial and the fungi. So, what's the mechanism? The antigen is going to capture, the antigen presenting cells are going to capture the antigen first, and they will present it to the naive T cells in the lymph node. They will release interleukin 12, making those naive T cells differentiate into TFR 1. And TFR 1 will now release gamma interferon to activate the macrophages. So the macrophages will get activated and they will now be forced to release tumor necrotic factor. Tumor necrotic factor is going to act on the macrophages, activate them the more, and they will undergo some changes. They become enlarged and they form epithelial cells. And those epithelial cells will now also fuse together to form giant cells, multinuclear giant cells. So all the cells that are important in forming the granuloma is almost getting complete. So that means that we have stimulated TFR cells, we have stimulated epithelial cells, we have stimulated multinuclear giant cells. So all these cells will now surround the antigen and wall it up as a granuloma. Then we said you want to be careful giving them anti-tumor necrotic factor, because if you give them anti-tumor necrotic factor, you will prevent formation of the epithelial cells and you also prevent formation of the giant cells. So the granuloma might eventually break down. It will break down and you can have a disseminated disease. For example, someone that has tuberculosis that is latent. The tuberculosis is just there in the body. The granulomas are the one encamping it so that it doesn't cause disease. When you now give something that will now lead to destruction of those granulomas, like TNF therapy, anti-TNF therapy, you break down those cells and they will have to let the bacteria go and start causing the disseminated infection in the body. Then we said those activated macrophages have increased enzymatic activity. What is this enzyme? 1-alpha hydroxylase. What does it do? It increased conversion of 25 hydroxycholecalciferol to 125 dihydroxycholecalciferol, which is vitamin D, which causes the absorption of calcium from the intestine, from the kidneys, from the bone, which is why some granulomas might be associated with hypercalcemia, particularly someone that has sarcoidosis. So we've talked about this. Then we talked about the differences between the scar that can happen, because in some situations you might just have a very clean scar, if the injury is not very severe. But in some situations, there may be a severe injury which will lead to increased elaboration of some growth factors that are involved in fibrosis, which includes the transforming growth factor beta, which you said that is very, very important in stimulating the fibroblast. So you have an excessive deposition of collagen tissue, so which can cause the hypertrophic scar or the keloidal scar. And we said for hypertrophic scar, the type of collagen that is there is essentially the immature one, is type 3. For keloidal one, is both of them, type 1 and type 3. The arrangement of the collagen in hypertrophic scar is very, very fine and parallel, but for keloidal, it's disorganized. The extent of the scar for hypertrophic is beyond the wound margin, while for hypertrophic is confined to the borders of the wound, while for keloidal, it extends beyond the borders of that injury. We said keloidal scar is essentially genetic, so if you remove it, if you exercise it, there's high tendency that you recur again. But for hypertrophic, it's very unlikely. And we said keloidal scar is very common in people that are dark, while hypertrophic scar doesn't have any predilection. So today we are going to be starting with neoplasia. So the word neoplasia just means new growth, and it is defined as uncontrolled monoclonal proliferation of cells. So you have a tissue that is made up of like 50 cells. If one of those cells now acquire a genetic aberration and is now dividing uncontrollably, that is a monoclonal proliferation of that cell. So that is one of the highlights of the neoplasia. The problem is starting from a single cell, monoclonal. It's not starting from cell A, cell B, and cell C together. No, it's only one cell that has that mutation, And because of that mutation, it is now dividing uncontrollably, giving rise to two daughter cells. Those two daughter cells also has that mutation in them. They too will continue to undergo uncontrolled mutation, and they will keep enlarging in number that way. So that is a monoclonal proliferation, which is typical of a neoplasia. So that is neoplasia. It can now be benign or malignant. So we might not be able to say that a neoplasia is tumor is benign or malignant by just mere looking at it. So we might want to do an histology to look at what is there. So we are going to talk about the differences between a benign and a malignant tumor later. So we should just know that a typical neoplastic mass has two components. The parenchyma, which is the neoplastic cell themselves. Let's say uh, the, the, the muscle cells now, the muscle cells. And there's a supporting stroma, that is some connective tissue that is giving a framework, that's giving a support system so that those cells can stay, as well as the blood vessels, the lymphatic vessels that are supplying blood and nourishment to that cancer, to that neoplasia. So two components, the parenchyma or the neoplastic mass themselves, and the supporting stroma that includes the connective tissue that is surrounding it, as well as the vessels that are feeding it. So let's look at the spectrum. Let's look at the spectrum from a normal cell to a malignant cell or to a neoplasia. So if you look at a normal cell, they have normal basal to apical polarity. So this basal to apical polarity is one thing that I want us to pay attention to. It's very, very common with respect to epithelial cells. So if you look at an epithelial cell, let's look at this image. Let's look at this image that we have here, image 1. So we can see that the blue line, so we have the epithelial cell on top and we have the basal membrane. You can see the basal membrane being labeled. Now, so the part of this epithelial cells that are attached to the basal membrane, that is the basal domain or the basal layer. So the part that is facing up, that is the epithelial, the apical layer. So if you observe them in the microscope, you will notice that they have different function. The apical layer is secreting. That's the part that secretes all the protein, all the electrolyte, they escape to that area into the lumen. While the basal one is the one that is attached to the basal membrane. We also have a lateral domain or the lateral pole that is the one that shares addition with the next cells. I hope we can all appreciate all what we are saying, the diagram. Can we see all these things I'm saying? You can see the basal layer here. We can see the lateral pole, which is the one that is connected to the next cell, and we can see the apical one that is on top. This polarity is lost in someone that has a cancer, because for you to even say something is a cancer, there's a high chance that the stuff will metastasize. There's a high chance that it's going to break off from the basal membrane. There's a high chance that it's going to get separated from the other cells. So you cannot even say, this is a lateral domain, because for you to say it's a lateral domain, that's the part that is attaching to the cells. You cannot say this is a basal domain because it has already separated from the domain. You cannot say this is a basal domain because it's the part that is attaching to the domain or to the basal membrane rather that you call the basal domain or the basal layer. So in a cancer, in a malignancy, you have loss of the normal basal apical polarity. Very important stuff. You see it in questions. You have loss of normal basal to apical polarity. So before you even get to cancer, normal cells can progress to dysplasia, just like we've talked about. But before they get to dysplasia, some of them will have undergone that hyperplastic or metaplastic change before they get to dysplasia. But what are those things that we see in a dysplastic cell? We said it then that we want to look at the cell entirely, we want to look at the structure, we want to look at the shape, the size. Is there uniformity or loss of uniformity? So for dysplasia, you expect loss of uniformity of the cell size and the shape, which is what we call loss of uniformity in the size and shape rather, which is pleomorphism. So there's also there's a pleomorphic change in that cell in which the size and the shape are abnormal. Then, in addition to looking at the cell entirely, we want to look at the nucleus. What is happening in that nucleus? We expect an increase in the nuclear cytoplasmic ratio. and we also expect clumping of the chromatin. It occurs in different grades: the mild, the moderate, and the severe. The mild, the moderate are reversible, while the severe is irreversible. So we also call the severe carcinoma in situ, pre-invasive form. That is why you see them separating it as stage 3. So at that point, the dysplastic change has extended from the apical part to the basal layer, but it has not breached the basal membrane. So that's what we call carcinoma in situ. But it is irreversible at that stage. It's just a matter of time. They are going to breach that basal membrane, and they are going to cause invasive carcinoma. That's the next spectrum. So invasive carcinoma now occurs when you have those epithelial cells breaching the basal membrane with the aid of some metalloproteinases like collagen, like hydrolates. They damage those basal membrane and they find their way into the connective tissue. So they can find their way into the extracellular matrix, and from there they can go to the other cells, or they can enter the blood vessels. We can see the picture here. So the cells are really leaving the basal membrane and they are finding their way into the blood vessels. So by the time they get to the blood vessels, they are attached to the endothelium of the blood vessels, and they travel with those blood vessels to other distant sites. So by the time they get to those distant sites, we are going to say that these guys have metastasized. So invasive carcinoma just means we have a breach in the basal membrane with the aid of some enzymes like collagenase and hydrolase. So collagenase and hydrolase are important for the epithelial cells to breach those basal membrane and escape. Sometimes, even before that happens, you might need to inactivate E-cadherin. So for invasive carcinoma to even happen, sometimes you might need loss of activity of E-cadherin. We are going to talk very well about this E-cadherin. So E-cadherin is just like an addition protein that helps to maintain cell-to-cell contact so that the cells are fixed together. So it has to function. It does this, and it also helps to initiate what we call contact inhibition. We are going to talk about it later. So in addition to doing that contact inhibition, it also helps to maintain cell-to-cell contact so that they don't move and separate. But in a cancer, in an invasive carcinoma, you have loss of that cadherin function. They're not there again. So those cells are free to move. So they can descend downwards. They release their metalloproteinase, breaks the basal membrane, and they get escape into the extracellular matrix, find their way to the blood vessels, and travel out as metastasis. So they can enter both the lymphatic or the veins, anyone they prefer. They don't enter the arteries, the veins, or the lymphatic. We don't have what's it called? Majorly they go through the venous route. Yeah, so I don't want to say they don't enter the artery. Please don't discard that information. Yeah, so they just say it's hematogenous. They can enter anyone, but most of the time they follow the venous side, and also they can also go through the lymphatics. So we want to talk about tumor nomenclature. How do we give them names?
Dr.
So
Bali.
yes, Dr. Precious.
Dr. Bali.
Yes, Dr. Precious, I
Please,
can
can
hear
you
you.
take that loss of cell? Can you take that loss of normal to apical cells polarity? I didn't get that. Yeah.
Okay. So look at this cell. Look at this structure that they are showing us. You can see one of these cells. You can see them. Uh, you can see that they labeled epithelial cell. You can see that, Dr. Precious. Hello?
Yes, I can see.
Yeah. So
Yes, I can see.
you can see that some of them are attached to the basal membrane. So let us focus on these
Mm-hmm.
ones that are attached to the basal membrane. So we can see the layer below. That is the basal layer. The layer of that epithelial cell that is attached to the basal membrane. That is the basal layer. Do you get that, Dr. Precious? So, hello? Hello, Dr. Precious. So maybe you should unmute. I want to be sure that you are following me. Hmm?
Yes, I get, no, I get that. I'm following you. I'm actually following you.
Yes. So we can see the layer that is
Mhm.
facing up. That is the apical layer. Then we can see the layer that is just at the lateral side, attaching to the next cell. That is the lateral layer. Now, we are saying in cancer cell, there's loss of the normal apical basal polarity. It's even loss of polarity of all the layers. Why? Because for you to have cancer, there's high tendency that the cells will have been separated from the basal membrane. There's high tendency that the lateral layer will have been separated from the nest cell. So those cells will just be hanging freely. So by the time you look at them in the microscope, the way you identify the basal layer of the cell is the one that is attaching to the basal membrane. Because of the fact that a cancer, they have all these hydroxylase and collagenase activity, they will have damaged or released themselves from that cell membrane, from that basal membrane, and you can't, when you are looking at them in the microscope, you can't even see anyone that is attaching to the basal membrane. So you can't say this is the basal layer, this is the apical layer, because they will have separated. So that is why loss of cellular polarity is a feature of malignancy. Do you get it, Dr. Precious?
No. Please, what is this polarity we're talking about?
Polarity, they are the poles. Look, can you guys see this image I'm showing you? The area that is facing up, that's the apical. The one that is attaching to the basal membrane, this green one, that's the basal. When you say polarity, the pole, apical pole, basal pole, lateral pole. Do you get it? Hello?
Okay.
Hello?
Yeah, okay, yeah. Yes, Dr.
So, if
But I can hear
somebody,
you. Can you hear me?
yes, if somebody has a cancer, you know that for cancer, all these cells will not be attaching to the basal membrane again. We have already said it for that for someone to have an invasive carcinoma, the cells will have invaded the basal membrane. Do you get that statement? So it means that the cells will have been separated from the basal membrane by the time they get to a cancer. You know that if a cell is still undergoing metaplasia, if they're undergoing dysplasia, they will still be fixed to this basal membrane. So if you look at them in the microscope, you'll still be able to see them attached to the basal membrane. And you can say that, oh, the part of this cell that is attaching to the basal membrane is the basal layer. The one that is opposite to it is the apical pole or the apical layer. But by the time you have a cancer, you don't have them attaching again. So there's loss of the apical basal polarity. I don't know if anybody gets what I'm saying. Please let me know before I just assume that we all
I
understand.
guess. Yeah.
Hello?
Dr. Babawale,
Yes.
hello. Yeah, so I understand your the explanation, but that lateral pole, is it when it becomes invasive? So that is when E-cadherin is inactivated, right?
Yes,
Based on what
exactly.
you explained earlier.
Yes. E-cadherin is also important in maintaining
From
cell-to-cell attachment, the lateral
pole,
poles.
the basal. Okay, then for the basement membrane to the basal pole, that's where the collagenase and hydrolase works, right?
That is it. So the first thing is
Just
E-cadherin
be
will
sure.
lose its action.
Okay, thank you.
E-cadherin will lose its action so that those cells cannot be attached side to side again. Then the next thing is when they are not attached side to side, that means that they are free to move. So they will want to come down to the basal membrane. They will now release their collagenase that will now hydrolyze the basal membrane so that they can escape outwards into the vessels. You get it? So that is the changes
Yes,
in
thank you.
invasive carcinoma. So let's start looking at the nomenclature. So when you say carcinoma, it means a malignant tumor that is of epithelial origin. Carcinoma, malignant tumor that is of epithelial origin. When you say sarcoma, mesenchymal tumor that is of malignant tumor that is of mesenchymal origin. So we are looking at two basic tissue type or cell type, epithelial and mesenchymal. Epithelial and mesenchymal. So malignant tumor of epithelial origin, carcinoma. Malignant tumor of malignant tumor of epithelial origin, carcinoma. Malignant tumor of mesenchymal origin, sarcoma. Now, what about the benign tumor? So, those ones are the OMA. They are just OMA. You will not have carcinoma or sarcoma. You can just have leiomyoma, or you have adenoma. So let's just go with the book so that it's very easy to explain. So let me just go with the way it's highlighted so that I don't cause any confusion. So let's now separate between benign tumor and malignant tumor. So a benign tumor is usually well differentiated, and if you look at it in the microscope, they are well demarcated. So they don't have irregular borders. They are confined within a particular arrangement. So they are well demarcated and they are well differentiated. So when we say a tumor is well differentiated, we are trying to say that that particular neoplastic cell is looking exactly or very similar to the LD cells that they are differentiating from, or they are what's the word now? We'll have a particular cell in a tissue. A tissue is made up of some cells. Now, we said for cancer to happen, you have to have one monoclonal cell, one cell undergoing a genetic mutation. That cell usually is very similar to the other cells too. So when you now observe that cell and you are now saying that, okay, that cell is still looking at the other surrounding LD cells from the same tissue that they are coming from, you say that they are well differentiated. But when you observe that cell that is undergoing that neoplasia and it is not similar to the surrounding cells, you say they are poorly differentiated. What it means is that that cell is actively growing so much that majority of the energy that it's getting is just channeled to growth. It just wants to continue proliferating. So it's very, very different from the other cell. In terms of the protein, they don't release the same protein. They don't have the same cell receptors. They don't have the same cell-surface marker. Everything has changed because the energy should be using to do all those things to make it alike like the cells it is coming from. They will not use it to do that. They will just channel everything to growth. So that is why malignant tumors show poor differentiation. They don't look like the background LD cells that is surrounding them. But benign tumor are well differentiated and they are well demarcated. So because of the erratic growth of malignant cells, they are not well demarcated. They just grow anyhow. They are just everywhere. If you look at the nucleus of a cell that is a benign tumor, they will show low mitotic activity. They are not proliferating rapidly like that. It's just very calm. It's more than normal, but it's not very much. So you are just going to see very few mitotic figures in the nucleus for benign tumors. They don't metastasize, that's why they are benign. And they don't show any area of necrosis because these guys are not growing excessively. They don't outgrow their blood supply. But all these things are reversed for malignant tumor. They show poor differentiation. They are very, very different from the background tissue where they are coming from. Very different. All the breast cells should be looking alike. That's what it should be. All the breast all the breast cells should be looking, sorry about that guys. All the breast cells should be looking alike. That's what it should be. But if a cell has undergone mutation and is not malignant, that cell is not going to differentiate itself from the other ones. That means it's using energy that it should use to look like other cells to make itself grow. That is poor differentiation. The growth is usually erratic. They can invade local tissues because of the malignant potential. We are going to discuss how they achieve all these things. The E-cadherin is also part of it. E-cadherin is inactive. They cannot confine themselves to the borders and they are moving away from that tissue, going elsewhere, going to the surrounding tissue. That is local invasion. So by the time it bridges that basement membrane and they go to the surrounding tissue, that is local invasion. By the time it breaches the basement membrane and it finds its way into the blood vessels to disseminate to other sites, that is metastasis. Now, I want to tell us that all these things we are saying, they are all marks of malignant tumor or cancers. Benign tumors are not cancers. They are just neoplastic cells, new growths, but they are not cancer. When you say cancer, that means you are saying malignant tumor. You are saying something that is capable of local invasion, something that is capable of metastasis, something that tends to show poor differentiation, something that has reduced apoptosis, because that's one of the hallmarks of malignancy. They show reduced apoptosis. They don't die through the normal typical mechanism. We are going to talk about this later. So now there are some confusing terms that looks like tumor, but they are not tumor. So one of them is called the hamartoma. So hamatomas just means disorganized growth of tissue. So what happens is that there's a genetic aberration right from development that is now making the tissues that is making up an organ to grow in a disorganized path. So you're having abnormal mixing of these tissue. You can have, for example, in the breast now, you can have mixture of the blood vessels, the fat cells, the glandular cells of the breast. They'll be mixing together. They should be separated. The fat should be here, the glands should be there, then the blood vessels should, be somewhere else. But when you have interposition of those tissues in an abnormal disorganized pattern, they will clump together and they will form a mass, which we call hematoma, or hamartoma rather. The difference between hamartoma and the other ones is that hamartoma doesn't grow at a rate that is more than the usual healthy tissue. But if you look at benign and malignant tumor, they grow more than the normal healthy tissue. It's just that the growth of benign tumor is not as high as malignant tumor. But hamartoma grows normally. It's just that the arrangement of the tissue that is making up that organ that is undergoing that hamartomatous change is abnormal. They are arranged in a disorganized pattern. An example of that is when you have a lung hematoma, which you call the coin lesion. So if you see a coin lesion on X-ray and you biopsy it, it's not malignancy. That is an hematoma. Hematoma of the lung, you can have hematoma of the breast, you can have hematoma of the colon in form of polyps. So they can form some hamartomatous polyps. And those polyps are part of the complex of Sjogren's syndrome. So we should not bother about this one yet. I know the old guys can remember. I've been a doctor. Who wants to quickly tell us the component of Sjogren's syndrome? Anybody? The old guys? We just say that one quickly so that we can move. Anybody? My chiefs are not here. Dr. Zuliat. Oh yeah, help from Macedonia.
Okay, because I'm trying to remember Sjogren's. Is it the same thing as Bechet, or is it the same thing? That name is just not ringing. Sorry.
No, it's not Bechet. So we discussed it in GI.
Is it the one with the hyper-segmented neutrophil?
Sjogren's.
Segmented purples in the mouth.
Okay. So you have
The
purples in the mouth,
oral cavity.
the oral cavity, in the hands, in the genitalia. Yes. Then you have the
Yeah, the polyps less than 20.
yes, you now have the polyps in the colon. So you have the polyps in
Okay.
the colon. These guys have a very high chance of transforming into GI cancers. So that is one of those things you want to watch out for. You can observe stomach cancer, colon, duodenum, different cancer from this background. So, once you see macule and you are seeing polyp, that is Sjogren's. So it's a form of hamartomatous growth. So this one is just disorganized arrangement of the tissues within an organ. In choriostoma, there's something called choriostoma. Now, this choriostoma is just a normal tissue. It's not a benign tumor. It's not a malignant tumor. It's not an hematoma. It's just a normal tissue that is found in a foreign location. For example, what we call heterotrophic pancreas. If you find a pancreatic tissue in the stomach, that's an abnormal location. Pancreatic tissue is a normal tissue. We are not finding it in an abnormal location, like the stomach. That is a choriostoma. Or you find gastric tissue in the ileum, like someone that has Merkel diverticulum. That is an example of a choriostoma. But in hamartoma, it is normal tissue that is there too. It's just that they are arranged and they are where they should be. They are in their native location. It's just that the arrangement is disorganized. So let's go to the nomenclature. The epithelium, the benign one, adenoma. So they can have finger-like projection as papilloma. So if they are malignant, you start adding the carcinoma to the end. So adenocarcinoma, papillary carcinoma. So when you see the word adeno, they are likely talking about a glandular epithelium. So you can have adeno arising from where you have glands. For example, gastric adenocarcinoma. So glandular epithelium of the stomach is undergoing malignant change. So if the gastric gland epithelium is undergoing a benign change, you call it gastric adenoma, not gastric adenocarcinoma. Once it becomes malignant, the carcinoma comes in. And if it's an epithelium, carcinoma must be there. So for the mesenchyma, all these tissue that you are seeing, all these cells you are seeing, they are mesenchymal cells. So blood, for example, blood is a mesenchymal cell. Blood cells. We are looking at the blood cell, white blood cell. So if it undergoes a malignant change, we call it leukemia or lymphoma. You remember that one of the hallmarks of malignancy is when it has disseminated. Can we have a blood cell being confined to an area? No, it's already the blood vessel, they are disseminated. So once somebody develops a tumor of the blood cell, it's already a malignant. So leukemia and lymphoma are malignant cells. Blood vessel, hemangioma, if it is a benign tumor. Angiosarcoma. So I already said it, when it comes to mesenchymal tissue, you want to add sarcoma to the end. Oma for the suffix, but suffix for oma for the suffix if it's benign, sarcoma for the suffix if it's malignant. So for the blood vessels, hemangio. Angio is actually the blood vessel terminology there, angio. So hemangioma, benign blood vessel. Angiosarcoma, malignant blood vessel. Anybody wants to tell us the risk factor for angiosarcoma? Anybody? Angiosarcoma, what are you looking out for?
Polyvinyl chloride.
You are looking out for polyvinyl chloride. You are looking out for radon. All those things can cause angiosarcoma. So then in the breast too, do you remember angiosarcoma, the breast? Angiosarcoma of the breast. Do you remember any risk factor for that you are looking out for as a clincher? Angiosarcoma of the breast. You are looking out for lymphedema. That's very good. Well done, Dr. Toby. So smooth muscle, the benign leiomyoma. Once it's malignant, you add the sarcoma to it. Leiomyosarcoma. So leiomyo is actually meaning smooth muscle. Rhabdo is striated muscle. You find striated muscle in the heart and in the skeletal muscle. So the muscle of the heart and the skeletal stuff, they are striated. Why the one of the smooth muscle, the one that lines the blood vessels, the glands and all those ones, they are smooth. So you don't call them striated, they are smooth. They have no striation. So that one is leiomyo. For the striated in the heart and the skeletal, you call them rhabdo. So someone can have cardiac rhabdomyoma. Can have a cardiac rhabdomyoma. You have been specific that this striated smooth muscle tumor is coming from that of the heart. So if it's malignant, you call it rhabdomyosarcoma. So smooth muscle, leiomyoma. So fibroid, smooth muscle of uterus, leiomyoma. When you have malignant tumor of the smooth muscle of the uterus, you call it leiomyosarcoma. When you have benign tumor of the smooth muscle of the stomach, of the uterus, you call it leiomyoma, which is fibroid. Malignant tumor of the smooth muscle of the uterus, leiomyosarcoma. Benign tumor of the skeletal muscle, rhabdomyoma. Malignant tumor of the skeletal muscle, rhabdomyosarcoma. Fibrous connective tissue, benign, fibroma. Fibrous connective tissue that is malignant, fibrosarcoma. So someone that is having ovarian fibroma, what is the syndrome? The old guys, ovarian fibroma. Ovarian fibroma. Where are my old guys? Are we still here or we have logged out? Ovarian fibroma. Does it mean
Jaggers syndrome.
What's the better?
Ovarian fibroma.
Meigs syndrome.
Meigs syndrome.
Meigs.
Meigs syndrome. So you are looking out for ascites and you are looking out for the left right fusion. Meigs syndrome, ovarian fibroma. Fibrous tissue of the ovary, they can develop a tumor which is can be benign as a fibroma or can be malignant, fibrosarcoma. Bone, benign tumor of the bone, osteoma. Malignant tumor of the bone, osteosarcoma. Osteosarcoma is very common. We talk about it a lot. Fat, lipoma. Lipoma, benign. Malignant, liposarcoma. Melanocyte is also part of the mesenchymal tumor. So if it's benign, you just call it the nevus or the mole. If it's malignant, you call it melanoma. Sorry guys, 1 minute. Okay, so I know that we are very familiar with these terminologies. So it's just more like a revision. So let's talk about tumor grade versus stage. So these are terms that we use to characterize those tumors. So for prognostic reasons. So when we say grade of a tumor, we are trying to talk about the differentiation of that tumor. So we've talked about it, that a malignant tumor, no, don't let me say that. Let me just say the grade is just talking about the degree of the differentiation, the degree, how differentiated it is. So you can have a tumor that's just having very low differentiation, or poor differentiation. They are very, very different from the cells that they are coming from. They don't look like them at all. We said they are anaplastic. That is an high-grade tumor. But if a tumor is having low grade or it is well differentiated, it is looking similar to the cells that is coming from. Like this one now, is looking like the cells that are forming the background, like it's close to them. You can see this compared to this one. This one is looking very different. You can see that this nucleus is looking deep, and the shape is not even looking alike. This one is not a well differentiated tumor. That is an high grade tumor. It's an anaplastic tumor. It's not well differentiated. It's likely to be malignant. So if you look at this cell now, it's looking a little bit similar as a background cell. We call it a low grade tumor, which is likely or less likely to be malignant. So that's that about grade. Very easy. Higher grade correlates with higher aggressiveness, higher tendency for you to metastasize, higher tendency for you to be malignant. That is it about grade. So grade is just talking about the differentiation. Is it well differentiated? Does it look like the background cells? Oh, this is a low grade tumor. It's likely to be benign. We look at the tumor. Is it high grade? Is it poorly differentiated? Like it's looking entirely like a different cell. That is an anaplastic tumor, and it is poorly differentiated. Okay, then we'll talk about the stage. So stage is just talking about the degree of invasion and spread of the tumor from the initial site. So we use the TNM staging. That's one stage that we use now that's one staging system that we use to stage a tumor. And it's based on 3 parameters. So from the level or from the order of priority in terms of how important they are. So we talk about the M. M is the most important. That's metastasis. It's a yes or no answer. M0 or M1. Is either it has metastasized or it has not metastasized. So that value can be M0 or M1. The next one in terms of the priority is the N. N is talking about the nodes. The nodes. Has it involved the nodes? So you can actually determine all this TNM staging based on your pathologic or your clinical findings. So when we say clinical, it's both combining your physical examination, your systemic examination with your imaging. You are doing a PET scan. In a system where technology is advanced, we don't waste time to be doing CT when we want to stage. Just go for your PET. Give you everything clean. But here we use CT. So you can use CT to look at all the tissues and establish if there's a metastasis from one part to another. You can also combine that with what you have palpated, what you have, so to know. So you can use your CT to detect a metastasis. Maybe someone has a breast mass and you are seeing some nodules in the liver in your CT. That is likely to be metastasis. Then you can biopsy to confirm. So if there's a metastasis, you can just grade it to be M0 or M1. So if there's a metastasis, that's M1. If there's no metastasis, that's M0. So the next one is the N, which is talking about the lymph node involvement. So you can establish that by your clinical examination, like palpating, you can do your palpation to see, okay, is there any lymph node involvement, or you can do a biopsy and check if there's any tumor in that lymph node of surrounding that particular tumor, or you can even do your imaging to look at all the nodes. You can establish that. So we can grade that node from N0 to like N3. We don't actually need to know this. We are not doing uh, molecular stuff. Nobody will ask us all these things. So it's just good to just know the basis for the staging. That's just it. Because the question can come in any angle.
Doctor, yeah, Dr. Valerie, this differentiation, I'm just looking at the images now. When they say well differentiated, I'm trying to compare what the low grade and the high grade.
Okay.
What exactly do you mean by differentiation? Because if you look at the pictures now, the high grade one that they say is poorly differentiated, it looks like there's actually more difference between the normal cells. So exactly, does it mean the difference between the normal and the abnormal?
Like you can see that this high grade one is looking very different from the background cells. You can see. That means that it is not spending its energy to look like the background cell. It is spending its energy to grow. So that is why it will not look like those cells. Because to look at those cells, you need to deposit some protein in some areas. You need to have some receptors. You need to configure your nucleus in a particular pattern. But it doesn't have time to be doing all these things. It wants to grow. So that is why we are saying a cell that is poorly differentiated, that doesn't look like the background cell, is likely to be malignant. And when we say something is not well differentiated or something is poorly differentiated, we say the grade is high. The grade is high. Do you get it, Dr. Murad?
So it does not look, so it doesn't look at all like the background.
It doesn't look
like
like
a poorly differentiated.
Exactly. Look at this other one. Look at this low grade. You can see that it looks like the background. It's just the color that is changing. You can see that it's looking like that. Look at the nucleus. Look at the cytoplasm. Look at the shape. They are looking similar. So this one is a low grade one. And this one is less likely to be malignant. Okay. So for the lymph node, you can do your examination, palpation, you can do your biopsy, or you can do your imaging. Then that's the R. So that's in N rather for your node involvement. Then the last one is the T. So T is the least important. So that is the tumor size. So the only way you can establish your tumor size best is by doing imaging. You do your imaging and you measure within the greatest dimension. That's it. You cannot do tumor size by doing histology. No. So that is why to establish this TNM staging, you need a combination of everything. Combination of your biopsy from pathology, clinical examination, as well as imaging. So you can use it to stage that tumor. So we can stage it. We can say we can say the tumor is T4. So that tumor size is ranging from T0 to T4 depending on the size. So they have some values that they assign to give it each class. So if it's between these values, say T2, that value T3, that value. So the higher the number, the greater the size. So you can even establish this T4. For example, someone that has a breast cancer by mere physical examination. A breast cancer that has metastasized to the skin is already T4. That's basic, T4. But the other one, T3, T2, you need to measure and assign a particular value. So let's say a breast cancer is T4 because it has gotten to the skin. And maybe you're only able to find it in like 2-3 lymph nodes, let's say N2. Then maybe there is no metastasis. That is M0. So that's a stage. So each of those stages, they have recommendations in terms of how you offer treatment. So that is it. So stage is actually more important when it comes to prognostic consideration than grading. The stage is most important, particularly when it's high, when it's like advanced stage, when it has metastasized. That's why M is the most important thing. Once you have achieved metastasis, that's advanced stage already. So you might want to be aggressive with your treatment for that. So that is that about the TNM stage. So don't forget, the stage is much more important than the grade with respect to those two more considerations. So let's talk about the hallmarks of cancer. That is, what are those things that cancer have that makes them cancer and not benign tumors? What are those things that make them malignant and not benign tumors? So we take those hallmarks one by one. To be honest, guys, I don't think we really need to cram it. So that's why I don't have a code to give us the list of the stuff. They will not be asking us, they will just give us a scenario and they will expect us to interpret it. You just need to you don't need to memorize it that, okay, good, apoptosis. No. Once you understand it, you'll be able to, answer the question. It's just basic understanding that is important. So the first hallmark for cancer is called growth signal self-sufficiency. So let me say that, let's just take a typical cell. Let's say which one can I use? Let me use the breast epithelial cell. So we know that the epithelial cell of the breast needs to be growing regularly. How does it occur? There will be a growth factor that will drive growth. But the problem with me using breast is that the receptor that I'm going to talk about doesn't actually get stimulated by a growth factor. Let's just assume that the growth factor in the breast epithelium, the growth receptor, needs a growth factor to stimulate it. So we are moving from up to down now. We want to achieve growth of the epithelial cell of the breast. There should be a growth factor. The growth factor should have a receptor. When there's coupling between that growth factor and that receptor, there will be some conformational change within the receptor that is going to activate some downstream processes. Most of them will activate some signaling molecule. Part of them is what we call the RAS. Another one is WNT. Another one is P13K. We don't need to cram all those things because there are a lot. We can't know everything. Let's just stick with RAS. So RAS is a signal molecule that can be activated from the receptors when they have coupled with their growth factor. The RAS molecule will now activate some downstream proteins. So those proteins will eventually activate transcription factors. But transcription factors are just factors that increases expression of a gene in terms of converting them to protein. So a transcription factor is a factor that will drive conversion of DNA to mRNA so that the mRNA can be translated into protein that will now do a particular function. What is the particular function we are talking about here? Growth. So that means that any transcription factor that we are going to be releasing is going to be mediated towards causing growth. An example of such transcription factor is MYC. So MYC is different from RAS. RAS is a signaling molecule that will lead to activation of transcription factors. Transcription factors will now jump in the nucleus and start converting the DNA to mRNA so that the mRNA can be converted to protein that will do some particular function. Part of the protein that they can produce, that a transcription factor that is concerned with causing growth can produce, is what? The cyclins and the CDKs. This is where we now have to apply our biochemistry knowledge. We know that cyclins and CDKs, they are what? They are cell cycle regulators. They want the cell to continue to enter the G1 to the S phase so that they will keep dividing and they will keep replicating. That is the way a growth factor can drive growth. Those are the processes. Now, if a cancer can in any way constitutionally affect any of these pathways, it will become malignant. It will become a malignancy or a cancer. That is, there's over availability of growth factor, or the growth factor receptor is working without any stimulation from growth factor, or you have excess signaling molecule like RAS dangling all about, or you have uncontrolled production of transcription factors producing growth proteins, or these growth proteins are even in excess like cyclin and CDKs. If mutation can happen in any of the genes coding for all these things, you have a cancer. And what mutation are we talking about? A gain of function mutation. That is a mutation that can increase the production of these guys. Any of these things that we have talked about. If there's a mutation that is increasing production of growth factor, that's cancer. A gene mutation that is increasing production of growth factor receptor, that is cancer. A mutation that is increasing production of signaling molecule, you can have any one of them. So that's what we call growth signal self-sufficiency. Any of the growth signaling pathway is self-sufficient. They are already available. They are constitutionally active. You don't need them to be stimulated. They are already stimulated. And they will continue to initiate growth in an uncontrolled manner. That is number one thing. Now, let's talk about the growth factors. So, genes that code for growth factors, they are known as proto-oncogene. Example of such growth factors is what we have is this platelet-derived growth factor. We have so many of them. Platelet-derived growth factor, epidermal growth factor, fibral growth, a lot of them. But when they now undergo mutation, a gain of function mutation, when we say gain of function, you have gained their function so much in an excessive manner. You can have a loss of function in mutation. A loss of function mutation means that mutation is suppressing the activity of that gene. A gain of function mutation means you are increasing the activity of that gene. Now, it will make sense for us to say that a gain of function mutation of a growth factor will lead to cancer. Makes sense. And it can make sense when we say that a loss of function mutation of a tumor suppressor gene leads to cancer. Because what tumor suppressor gene initially will do is to inhibit growth. For example, TP53, they don't want growth to happen. They want cells to be dying. When you now have loss of function mutation of something that codes for TP53, that means all the cells will not die again. There's nothing to stop them. There's nothing to make them die. It just will proliferate. That is the terminology. So let's go back. Mutation in the gene encoded the proto-oncogene. So that means that you have elaboration of the growth factors, and by that time they undergo mutation, you call them oncogenes. They are no longer proto-oncogene, they are now oncogene, and they elaborate a lot of growth factors that will keep stimulating on the receptors in an autocrine loop, leading to cancer. Example of that is when you have increased level of platelet-derived growth factor in brain tumors. Another one is, okay, you are not affecting the growth factors, but can you affect the growth factor receptor? There is constitutional activation of the growth factor receptor. Example, human epidermal growth factor receptor. Human epidermal receptor. This receptor, HER2, is located within the breast and the gastric mucosa. So that is why anybody that have constitutional activation of HER2 can have breast cancer and they can have gastric cancer. We should not forget that. Anytime we see HER2 in the question, breast cancer should come to our mind first. Very, very important. Is a growth factor receptor. This growth factor receptor, they can activate signaling molecule. So if you have a gene that is overproducing signaling molecule like RAS, you can have cancer. If we have mutation of a gene that is overexpressing transition factor like MYC, we will have cancer. Because transition factor will eventually activate cyclin and CKD that will start driving the cell to G1 to S phase by inactivating retinoblastoma. And you have cellular proliferation that is uncontrolled. Or you have a gene that is mutating our cyclin or CKD, making them excessively produce. There's a cancer. Let's go to the next step. That is growth factor signaling insufficiency. The next one is anti-growth signal insensitivity. Now, we have something that supports growth. What about the one that inhibits growth? What would they do to them? The cancers, for them to become cancer, some of them will just pay deaf ear to those anti-growth signals. One example of anti-growth signal is retinoblastoma. If you remember, our cyclin and our cyclin-dependent kinase complex, they inhibit retinoblastoma by phosphorylation. So once they phosphorylate retinoblastoma is the gatekeeper of the G1 to S phase of cell cycle, of cell division. So when they take out that retinoblastoma, you have uncontrolled progression to G1 to S phase. So that means you have the cell replicating uncontrollably. So some tumor can develop malignancy by what? By inactivating retinoblastoma, by causing loss of function mutation in retinoblastoma, which is anti-growth signal insensitivity, because there will not be any anti-growth signal to stop them. They are insensitive to anti-growth signal because they have neutralized it. That's another way. It's either you fast track the availability of a growth factor stuff pathway, or you inhibit the growth inhibiting signals like retinoblastoma. Another growth inhibitory signal that is in the body normally is E-cadherin. Now, we said E-cadherin is responsible for maintaining cell-to-cell contact so that the cells will not be able to move freely and traverse the basal membrane and go to the blood. There's another function of E-cadherin again. So, in addition to E-cadherin allowing those cells to adhere together, once they adhere together, there's something we call contact inhibition. Any two cells that have adhered together and they are touching each other with the aid of that E-cadherin, they inhibit themselves from growing. So once contact is achieved, there's inhibition of growth. That is contact inhibition. But if there's loss of E-cadherin, there's no contact again. There's no growth suppression again. They begin to proliferate uncontrollably. So we can safely say that E-cadherin presence is an anti-growth signal. So when we take out E-cadherin, there's a loss of an anti-growth signal, and there's loss of contact inhibition of growth, and there is unopposed growth, which can lead to cancer. An example of such cancer is any cancer that is losing E-cadherin, like some gastric cancer, or someone that has neurofibromatosis type 2. In these people, they have mutation of what we call Merlin gene. That Merlin gene is also like E-cadherin. It also maintains contact in the cell so that there will be inhibition of growth. When they touch each other with that molecule, they are inhibited. But once that Merlin gene is not there, the cells are separated. They begin to proliferate abnormally because of loss of contact inhibition. Those two, retinoblastoma and those contact inhibition protein, they are anti-growth signals. Some tumor cells might not use growth efficiency problem. They might not use anti-growth insufficiency. What they will now want to use is what? Evasion of apoptosis. They don't want to die. They want to be everlasting. So what will they do? They will go and inhibit TP53. They know that TP53 is the one that is activating back and backs. Back and back. So they will inhibit that TP53 so that there will not be any back and backs to be making holes in the mitochondria so that caspase can come out. Or cytochrome C can come out to activate the caspases. So they will evade apoptosis and they will live forever. Or they can continue to overexpress BCL2 because BCL2 is an anti-apoptotic factor. It opposes the activity of the back and the backs. So if there's an overexpression of the BCL2, the cells that are overexpressing that BCL2 will live forever. So that is the basis of follicular B-cell lymphoma because of overexpression of BCL2 in the B cells, which is an anti-apoptotic factor, unlike TP53, which is an apoptotic factor. So they will suppress TP53, they will overexpress BCL2. Some of them have limitless replicative potential. That's the mechanism by which they are causing malignancy. How will they achieve this limited replicative potential? They will, because replication should be limited. Whenever a cell has achieved 50 to cell division, it should die. Normal. That's how it should be. It should die by apoptosis. You have divided 50 to 60 times Abi. It is now time to go home to Baba God and they will die. But what is actually labeling those cells for death is what we call shortening of the telomere. There is some sequence of RNA, DNA that is attached to those chromosomes of those cells, so that with each division you are having shortening of those telomere, and when it shortens to a level, it will activate the apoptotic gene so that they can take it off by apoptosis. Now, cancer cells will now go and activate telomerase, which is a DNA-dependent, which is an RNA-dependent DNA polymerase. An RNA-dependent DNA, when we say RNA polymerase, DNA polymerase, is not a big term. RNA-dependent DNA polymerase. You see, the one that is ending, either RNA or DNA polymerase, anyone that is ending it is what you want to produce. So if I say RNA-dependent DNA polymerase, that means I want to produce DNA from RNA because I'm depending on RNA. So telomerase is an enzyme that converts RNA to DNA because those telomeres, they are DNA sequences at the ends of the chromosomes. So if I want to lengthen those telomeres, I want to increase the DNA sequences, I'll just employ the activity of my RNA dependent DNA polymerase that will help me produce more of them so that it doesn't shorten and they don't label those cells for apoptotic removal. So they will persist for life. That is limited replicative potential. That's another way by which malignancy can start. Some of them just have sustained angiogenesis. So what they will do is that they will elaborate angiogenic factors like vascular endothelial growth factors, and they will suppress inhibitory factors like thrombospondin. So when they suppress inhibitory factors and they increase pro-angiogenic factors like VEGF, they produce a lot of vessels. So those vessels are going to deliver more nutrients, more oxygen, more blood, more protein, more carbon, so that they can grow widely. So sustained angiogenesis is very important for malignancy to kick in. With those vessels, they were also able to disseminate into the other region of the body. So they can do this by two things, and those factors can come from two sources. They can come from the neoplastic cell directly, the parenchyma, or they can come from the stromal cells. So the vessels can come from two regions, particularly. They can come from existing capillary. So you call that neoangiogenesis. That is, you want to produce new vessels from existing vessel. You call that neoangiogenesis. But if you want to produce it from the bone marrow, you want to recruit endothelial cells from the bone marrow, that is vasculogenesis. So if you recruit vascular cells from the bone marrow, the endothelial cells from the bone marrow, that is vasculogenesis. You are generating from the bone marrow. But if you are making new cells from the existing capillary, that is neoangiogenesis. So all of them will still culminate in the production of new blood vessels. Then there's something we also call the Warburg effect. So Warburg effect is also important to sustain those malignant cells. The Warburg effect is talking about shift in metabolism of glucose away from mitochondrial oxidative phosphorylation towards glycolysis, so that they'll be generating little ATP, fine. But in the presence of oxygen, glycolysis will be happening and oxidative phosphorylation will not happen. That's why we call it aerobic glycolysis. And that is important so that the only intermediate they will be forming is pyruvate. And pyruvate will be able to go back to all the substrate in our glycolysis. You guys should picture all those substrate that is upstream to pyruvate. We remember that we'll get to, as we are going back, we'll get to glucose 6-phosphate. And we said that glucose 6-phosphate is the one that enters the HMP shunt that will form ribulose 5-phosphate when NADP act on it. NADP will act on it so that it will get converted to ribulose 5-phosphate. And we said ribulose 5-phosphate is the substrate that helps to produce our purine bases so that we can form DNA. They will also generate carbon sources to form our lipids and our protein and the other things. And those dividing cells need all those carbon structures, the DNA, they need the protein and the other things so that they can sustain from themselves. They cannot get that when they are breaking the pyruvate down. They cannot get that. So what they will do is that they will just convert pyruvate to lactate. As pyruvate is getting converted to lactate, it can easily get converted back to the pyruvate again. We remember all those cycles now, our Cori cycle, Kai cycle. So the Cori cycle help us convert our lactate back to pyruvate. So we have pyruvate sufficient to go back to all those metabolites that will give carbon sources so that it can generate more DNA, more protein to divide. That's what they need. That is Warburg effect. So glucose will not be getting converted to pyruvate to enter TCA cycle. No, the glucose will just be getting converted to pyruvate only. So pyruvate can get converted to lactate so that it can generate little ATP, and the lactate can get converted back to pyruvate. Lactate dehydrogenase is what catalyzes both reaction. We know that is reversible, both of the pathways. So from the pyruvate, they can now go upstream to generate some other intermediate that can, supply those carbon atoms. Please, I hope we understand what I've said about the okay. Do you remember those pathway in BCH the one that is upstream to pyruvate. We are coming from up to down, glucose to glucose 6-phosphate to fructose 6-phosphate to fructose 1,6 to glycerol 3. You remember all those division?
Yeah.
Yeah. So, and you know that pathway can be reversible. You can go from pyruvate up again. Like you can go back. You can go back. So that means that what you want to do
Yeah.
is that don't convert all your pyruvate. You know that if you take pyruvate to oxidative phosphorylation, you have degraded that pyruvate. It's no longer available. So why not convert
Yes.
pyruvate? Why not convert pyruvate to lactate so that I can generate 2-ATP and manage it? Then that lactate, convert it back to pyruvate so that the pyruvate will now go back as if you want to form glucose. Do you get it? But it will form some intermediate in the process. Like I don't want to open our biochemistry stuff, but I think I have to open it. Let's just go back to that part we are looking at. What we are saying. So this is what I'm saying. Instead of taking pyruvate to oxaloacetate so that I can enter TCA, don't do, converting pyruvate to acetyl-CoA rather so that I can enter TCA. We are not doing that. What we are doing is just converting this pyruvate to lactate. We convert our glucose to pyruvate by glycolysis, and glycolysis is going to yield pyruvate, and we are going to move that pyruvate to lactate. Generate 2-ATP. You can see this arrow that is reversible. You can see that you can convert the lactate back to pyruvate. Dr. Paulette, you can see.
Yes.
That reaction can go back again. It can go back. You can see that almost everything is reversible. You can go back again. Then the one that is important is actually glucose 6-phosphate. By the time they form glucose 6-phosphate will now enter HMP to form ribulose 5-phosphate. You see this ribulose 5-phosphate, it is the source of the carbon atom. You know that when we are forming DNA, we are using nucleotides, and we said part of the nucleotide you have a phosphate group, you have a nitrogenous base and a ribose sugar. You get?
Yeah.
So that this ribose, all of those ribose sugar, they are coming from this ribose 5-phosphate. So it means that if you have
Yes.
enough ribose 5-phosphate, you can form more DNA so that those malignant cells can use those DNA to replicate. They can have ribose 5-phosphate to replicate their DNA, and they can be more in number. Do you get it?
Yes.
So it's because of the fact that they have enough pyruvate to go back. But just imagine that they are converting their pyruvate to TCA. They are breaking it down. There's no pyruvate again. How do you think they are going to generate carbon atoms? There's no way. So that is why they want to use the Warburg effect so that they don't undergo the oxidative phosphorylation. They just have what's it called? Glycolysis, and they move. So do you understand it now, Dr. Paulette?
Yes, I do.
Okay.
Thank you.
You're welcome. So that's that about the Warburg effect. Don't forget that stuff, Warburg effect. So immune evasion in cancer is another thing, because just imagine cancers are lying all around. They should have something to protect themselves, because if they are not protecting themselves, they will be taken care of by the immune cells. So another hallmark of malignancy is that they are able to evade immune cells. So there are 3 mechanisms by which they do that. Number 1, they downregulate the MHC class 1 expression on them so that the cytotoxic T cells are not able to recognize them. Do you guys think they've even done anything if they downregulate MHC class 1 in their surface? What do you guys think can happen when this happens? Of course, they've downregulated the MHC1. They will not be recognized by the T cells. Fine. the cytotoxic T cells. But something else happened. Anybody, I just want you guys to just go back to that immunology and look at it. We downregulate MHC class 1. It can stimulate something. We have forgotten. No. So we don't remember downregulation of MHC class 1. Dr. Kenna, you want to say something? Yeah?
We don't know.
We did what?
Can I just say?
You said?
We may know.
Hello?
Don't worry, never mind. I'm not
Yeah.
saying anything important.
Okay,
Hi.
so if there is downregulation of the MHC1, we said it that it can actually activate the natural killer cells. That is one thing. When there's downregulation of MHC class 1, that can be a signal to activate the natural. That is why these tumor cells, they don't stop at that level. So in addition to downregulating MHC so that they cannot be recognized by the cytotoxic cells, they will now also secrete immunosuppressive factor like TGF. And they will now recruit the activity of the regulatory T cells so that they can release interleukin-10, TGF-alpha that can suppress inflammatory response. So all the natural killer cells, cytotoxic T cells, none of them will be able to recognize those cancer cells. Then the last thing they do, in addition to releasing immunosuppressive factors or downregulating the MHC class 1 on them, is to what? Is to upregulate some immune checkpoint molecules. So we are going to talk about the immune checkpoint molecule very soon here. So let's just continue. So the next thing is tissue invasion. So they can invade tissues. They can go from their side to other side. So that is by losing the activity of E-cadherin, just like we have said. So once they lose E-cadherin, they'll be able to separate from each cell. The intercellular connection has been lost. Then they will now descend. They will now release their metalloproteinase to degrade the basal membrane and the extracellular matrix. They will now attach to the proteins elaborated from those extracellular matrices like laminin and fibronectin. Then from there, they will now find their way to the vessel because we have showed us that picture. So by the time they degrade the basal membrane here, the next thing they are seeing is the vessel. Just enter the vessel like that. And metastasis happens. So that is tissue invasion. By the time you are able to degrade the basal membrane and enter the extracellular matrix, that is tissue invasion already. So by the time you now seeds into the vessels, that is metastasis. So they enter the vessels, they enter the lymphatics or the blood, they adhere to the endothelium there, and they extravasate. So that endothelium they are going to adhere to the endothelium and travel with the blood. By the time they go to the site that they want, they will now extravasate. They will now move across the endothelial cell into those tissue. That's the extravasation, just like the neutrophils. They extravasate into. There's something we now call homing. Homing is now when they try to make that place their home. So they try to acclimatize, they try to adjust. They start producing new blood vessels. Then they will now form secondary tumors at that start. That is what we call homing. So if extravasation and homing has occurred, that we say there is a complete metastasis. So the most common site that they stay, is actually the organ that is supplying the first capillary bed that they encounter. For example, if somebody has a colon cancer and that cancer is able to seed into the superior mesenteric vein or the inferior mesenteric vein. Let me say superior mesenteric vein. Superior mesenteric vein and the splenic vein, they join together to form the hepatic portal vein. Hepatic portal vein supplies the liver. So it makes sense for us to say that one of the most common sites of metastasis, if not the most common site of metastasis of the colon, should be the liver. Because by the time the tumor enters the superior mesenteric vein, they join with the splenic vein and they enter the hepatic portal vein and they supply the liver. So the liver is the first thing that they enter. So that is the first capillary bed that is encountered. That is the first organ that they will infect. Although some cancers still show tropism, like lung cancer, it has affinity for going to the adrenals. It has affinity for going to the brain. Please don't forget, lung cancer has a very high affinity for going to the brain. So different studies, are giving different reasons. So most of them are just talking about the fact that the cancers and these organs release some interleukins that kind of attract themselves to that area. So that is just about the tropism. Tropism is just meaning affinity for a tumor to go to a particular organ, just like the lung going to the brain or the adrenals. The prostate goes to the vertebrae, although that one is not more like tropism. It's due to the venous drainage. Yeah. So okay, so let us talk about the immune checkpoint. Immune checkpoints are just checkpoints or interactions between a T cell, a cytotoxic T cell, and antigen presenting cell or a tumor cell, just like we can see in this image. There are some checkpoints here. So this checkpoint, there are some changes that can happen in this checkpoint that can influence the activity of the T cell. Now let's look at the first one. We are looking at interaction between a T cell and an antigen presenting cell. Now, we already know that we have two signals for T cell. The first signal, which is between the MHC and the T cell receptor, then the co-stimulatory signal, which is between the B7 on the antigen presenting cell and the CD28 on the T cell. Now, in some situations, let's say that the antigen presenting cell has presented the antigen to the T cell and the T cell has done the inflammatory response and they are done. What the T cell will now do to stop its activation is now to elaborate what we call CTLA4. When they release that CTLA4, it's now going to bind to B27, so that B27 will not be able to bind to CD28, so that the T cell will now not be co-stimulated again. It will now undergo this energy and it will not do immune response again, so that you can have suppression of immune response, so that you don't have overreaction, so that autoimmunity doesn't develop. Now, we have now, based on the knowledge of molecular biology, used that interaction to our own advantage. So what we are now doing is just to devise a drug that can inhibit that CTLA4, so that when a T cell is activated, it becomes activated for life, not for life, for a long time, so that it can continue to do its function, particularly in the setting of malignancy, because we know that it is only the T cell that can basically take care of malignancies very well. So why not continue to activate that T cell for a long time? Don't even let them rest. So that is the basis of developing an antibody against CTLA4. Example, ipilimumab. Ipilimumab is a monoclonal antibody against that CTLA4. So they bind to that CTLA4 so that the T cell will remain constitutionally active and bind and take care of the cancer. That is one immune checkpoint. And that immune checkpoint is between the tumor cell and the T cell. This one is actually utilized by the tumor cell to suppress the activity of the T cell. What they will do is that there's something we call PD1 that is on the T cell, and the PD1 ligand on the tumor cell. So some tumor cells, they are able to evade immune response by what? By elaborating this PD1 ligand, so that once that PD1 ligand binds to the PD1 on the T cell, it will inhibit that T cell, and the T cell will not be able to recognize them, and they will evade host immunity. That is the third option that we are saying here. Tumors upregulate immune checkpoint molecules which inhibit immune response. So they will upregulate the level of the PD1, they will upregulate the level of the PD ligand, so that PD ligand will now bind to the PD1 on the T cell and suppress it, so that the T cell will not be able to recognize them or attack them. So what are the monoclonal antibodies that can develop against CTLA4 that we can give, so that we can permanently inhibit CTLA4, so that there's nothing to inhibit the co-stimulatory signal, so that we can have continuous activation of our T cell? So such antibody includes pembrolizumab. I think that's the only important one that we need to. Even we don't need to memorize that name, because if they want to put in the question, they will tell you what the antibody is doing. They can tell you that, okay, they are giving a monoclonal antibody that is inhibiting CTLA4. And we already know that CTLA4 is a receptor that blocks the activation of T cell. It's the one that helps us suppress the immune response. So once you block CTLA-4, that means I want to activate the T cell for a long time so that it can attack cancer. So that's why we want to use that antibody to treat cancer, because we will permanently activate that T cell so that it can attack the cancer cell. So such antibody is pembrolizumab. Pembrolizumab. I'm sorry, I said pembrolizumab. Ipilimumab, that's CTLA-4 antibody. I'm sorry, guys. Yeah, ipilimumab. But we can also give antibody. So because we know that, okay, some tumor cells, the logic that they do now is just to elaborate PD ligand so that they can inhibit PD-1 on the T cell, so that they can suppress the T cell and the T cell will not be able to respond to them. So we have now devised antibody against both PD-1 and PDL1 so that we can inhibit that interaction and we can have the T cell responding to the tumor cells. So you can develop antibody against PD-1 on the T cell or against PDL1 on the tumor. So that is, so for the PD-1, that is for the PDL1, that is all this atezolizumab, duva. See, guys, to be honest, like, if you want to learn it, it's fine, but I don't think it's going to be an application question. They will not expect you to be cramming names of drugs. So yeah, but it's fine if you want to know it. Atezolizumab, avilumab for the PDL1. But the one that they commonly act is the PD-1, the one that binds PD-1, and that is pembrolizumab. And the PD-1 is located in the T cell. PD-1 T cell, PDL1 tumor cell. The ligand is on the tumor cell, the receptor is on the T cell. So what the tumor cell will just do is to upregulate the ligand so that it can bind to the PD-1 on the T cell to suppress the activity of T cell. So as anti-cancer therapy, we are not giving antibody against PD-1, which is pembrolizumab, or we can give antibody against PBL1, which is avilumab or atezolizumab. Please, guys, I want to know, do you guys understand all these interaction that I've talked about now?
Yes, it makes sense, especially the one for the CTL.
Okay, yes. So CTLA is there to bind to B7. So that is the application of all this knowledge. Once we're able to understand what is happening in immunology, it's very easy to understand all these things. You just need little effort to get it. Once your immunology knowledge is there. So you already know that CD28 has to bind to B7 so that they can activate that T cell. So, and T cell has a way of deactivating itself by releasing CTLA-4. So it makes sense for us to now give a drug that inhibits CTLA-4 so that the T cell can remain constitutionally activated to take care of cancer. That is the usefulness of giving an antibody that inhibits TCLA4. Or you can also treat cancer in a reverse manner by giving an antibody that will block their PDL1 that they express, or block PD-1 on the T cell, because the PD-1 PDL1 interaction suppress the activity of the T cell. That's the way cancer suppress T cell activity, and you have figured that out. Give antibodies that will block two of them. There's no way that T cell will escape. There's no way the tumor cell will escape. The T cell is going to attack it. So that is it. So cancer epidemiology. So in the US, skin cancer is the commonest. It's the most common. And from the types, we have the basal cell carcinoma is the commonest, followed by squamous cell carcinoma. Melanoma is rare. Now we have established that fact. So let's now talk about the other ones in terms of their incidence and mortality. So it's very easy to remember. So we should just know that in terms of incidence, prostate is the commonest for male, while breast is the commonest for female. Females don't have breast. Sorry, males don't have breast, and females don't have prostate. So it is what they have respectively that is the commonest in terms of the incidence. So males, the commonest cancer is prostate. For females, breast. Then the next ones are equal for both of them. Lung is the second one for male and female. Colorectal is the third one for male and female. But in terms of cancer mortality, it changes. We are only going to change the first and the second. So lung is going to be, because lung is more deadly. It kills a lot in the US. Although heart disease, all these MI and the like, they are the number one killer. So, but taking that out of the way, looking at malignancy, lung cancer is the second in command in terms of the cancer that causes most mortality. So you just reverse it, bring lung cancer up. So both of them lung, then you continue the arrangement. Prostate is the next one, then colorectal third. Then for female, breast is the next one, colorectal third. So that's the way it is for the adult male and female. So for the children, it's just leukemia number one. So they die of blood cancer more. Leukemia, they die of CNS malignancy. So all these glioma, multiforme, and all those things can kill them. Then the third one is neuroblastoma. So for children, leukemia is number one. Second one is CNS. The third one is neuroblastoma. So we should pay attention to that. Leukemia for children first, CNS cancer the second, then neuroblastoma the third. Okay. Then let us talk about the site of metastasis. So most carcinoma spread by lymphatic. That's a rule. Most of the carcinoma go by the lymphatics. The sarcomas go by blood, hematogenesis. So the acronym is CLASH. CL, carcinoma lymphatic, and SH, sarcoma hematogeneous. So sarcoma hematogeneous, CH, and SH and CL. So carcinoma lymphatic, sarcoma hematogeneous. So that's it. Those are the rules. However, there are 4 carcinomas that only go hematogeneously. They don't go through the lymphatics. There are 4 carcinomas that don't obey that rule of following the lymphatics. These ones go by the blood. So I tried to devise an acronym to help me, but I could not figure out one. I don't know if you guys can help. So the way I learned it is just renal and liver. They are always together. So hepatocellular and the renal cell, that's one. Then I just had my choliocarcinoma and follicular thyroid to it. So follicular thyroid carcinoma, choliocarcinoma, liver and lung. Liver and kidney is complete. Liver and kidney, follicular thyroid carcinoma, and choliocarcinoma. So I'm trying to look for a word I can form from FCRH. It's very difficult. So follicular thyroid carcinoma, choliocarcinoma, renal cell carcinoma, and hepatocellular carcinoma are carcinomas that don't go through the lymphatics. They go through the blood. So we have 4 basic sites of metastasis that if you see a cancer in those regions, it is likely to be met. It is likely to be metastasis and not primary tumor. What are these 4 regions? BBLL, the bone, the brain, the liver, and the lung. So the bone, the brain, the liver, the lung, the bone, the brain, the liver, the lung, the bone, the brain, the liver, the lung. So once you see a malignancy happening in the liver, the bone, it's likely to be a MET and not primary malignancy arising from those regions. And one way you can also tell that something is a MET is when you see that there are so many lesions. It's not only one. It'll be like more than 4, 5. But for primary, most of them, they're usually solitary for primary. So let's look at this site of metastasis one by one and look at what goes to them. So the rule is all of them. The second, actually, I feel that what we need to know is actually the first 2 or the first 3 maximum. Just know the first 3 tumors that go to each of those sites commonly. For example, bone. What are the first 3 tumors that go to it? Liver, first 3. You can't know 5. No, it's not. There's no need. They cannot be asking us that what's the 4th most common tumor that goes to the bone. That doesn't make any sense. So what do we want to do with that information? So I feel that the first 2 or the first 3 is okay to learn. So the code is breast is central to all of them in the second position. So breast is in the second position to all of them. Breast. So looking at bone, the number one tumor that actually lies going to the bone is the prostate tumor. So because of it has tropism for the bone, particularly the vertebrae. That's where it goes to, the vertebrae, because there's the baston venous plexus that runs through the vertebrae to the CNS that the prostate empties into. So it can easily disseminate to the vertebrae. They usually have back pain, vertebral collapse, prostate. So prostate, don't forget, bone. That's the first thing about prostate. Pathological fracture, all those things. Bone. Then the next one is usually breast. So breast is always in number 2. Then the third one for bone is the lungs. So lungs also goes to the bone. Now, there's something about this bone. They have predilection. Anything that is going to the bone, they typically have predilection for the axial skeleton. That is skeleton from the head to the sacrum. So anything from the, let's see if I can have a picture of the axial skeleton so that we can just understand what I'm saying when we say axial skeleton. So axial skeleton. Okay, so we can see the image here. So head to the sacrum, ribs, the head, the neck, the ribs, the vertebrae, then to the sacrum. That is axial skeleton. So appendicular skeleton is the upper limbs, lower limbs, pelvic girdle. Pelvic girdle, yeah, pelvic girdle, the pelvic bone, then the upper limbs, the lower limbs. That is appendicular skeleton. So axial skeleton is the site of metastasis of all those tumors that go to the bone. And we said number 1 is prostate. Number 2, which is always everything, number 2 is breast. Then the last one, lungs. So there's something about bone metastasis that they ask too. Some of them are blastic, some of them are lytic. So when you say it is lytic, it means that it is causing resorption of that bone. It is reducing the bony mass. It is reducing the bony mass. It is causing resorption of the bone. It's lysing it. Some of them can be plastic. They're actually depositing extra mass to the bone. That's what they are doing. Once the tumor deposited, they deposit extra mass. But that extra mass that are depositing doesn't make that bone stronger. No. It's not a normal, complete, well-formed bone. It will weaken that bone. Yes. And some of them are mixed. They show more plastic and lytic activity together. So let's take them one by one. So the code for the plastic one is just to know that prostate is plastic. Prostate is plastic. And I try to assume that the plastic one are not very aggressive like that. So I just say, okay, small cell carcinoma. Though small cell carcinoma is that code might not work because small cell carcinoma is a very bad guy. But the thing is, the small cell carcinoma and the prostate, they are plastic. They don't cause lysis. The other ones will cause lysis, particularly multiple myeloma. I don't know why multiple myeloma is not here. Is commonly said. So multiple myeloma is lytic. Kidneys, renal cell carcinoma is lytic. Non-small cell carcinoma of the lungs, they are lytic. So the non-small cell, they are lytic. While the small cell, they are plastic. Then prostate too, they are plastic. So all these things might actually need little memorization. We just have to learn by heart. So, but I just stick with it. Okay, prostate and small cell, they are plastic. Then the breast is one that has a mixed. Breast is mixed. Then the lytic ones are the aggressive ones, like the renal cell carcinoma, like the multiple myeloma, and the non-small cell carcinoma of the lungs. So if somebody has adenocarcinoma of the lungs, large cell carcinoma of the lungs, bronchogenic carcinoma, all those ones, they are lytic. So the next side of metastasis is the liver. Just like we said, from the example I gave us, the colon draining into the liver through the hepatic portal vein. The most common organ that drains to the liver, that metastasizes to the liver, is from the colon. because of what we have said. Then we already know the number 2, breast. Then the number 3 is pancreas because they are all gastrointestinal structures. Liver, colon, pancreas. So it's very easy to learn. You just see the met dispersing throughout the entire parenchyma of the liver. So for the liver, colon, number 1, because the supramesenteric vein drains into the hepatic portal vein and they can go to the liver directly. Then the next one is the breast as usual. Then the third one is pancreas. Then the lung. Lung 2 is colon. So colon and so the epidemiological stats for liver and lung, they are very similar. The first 2 is colon and breast. Colon and breast are the first 2. It's only the third one that is changing, which is kidney for the lung. So kidney, lung. So the way we can remember the lung one is that, okay, colon and breast. Then lung is bilateral. So it has to come from another bilateral structure, kidney. So kidney is bilateral too. So it goes to the lung. And when you see lung metastasis, it usually affects both lungs. Then the last one, the brain. So we said it then that lung cancer has predilection for going to the brain. So lung is number 1, tropism number 1, then breast as usual number 2, then melanoma number 3. So they typically settle at the junction between the gray and white matter. So it's believed that the vessels that are at this junction have some characteristics that can slow down those tumor cells and make them stay there. So that is it. They make those tumor cells deposit themselves in that area because of the dynamics of the blood flow within the gray water junction. So let's take them again. The bone, number 1, prostate. Number 2 is the breast, and the third one is the lung. We might not remember that third one, it's not important. Then it can be blastic or lytic. So for the blastic, prostate and the small cell. For the lytic, non-small cell, renal cell, multiple myeloma, colon, and the other ones. They are lytic. Then the breast is a mixed, both lytic and blastic. Then we're talking about liver. We must always remember colon. That is the one that is draining to the liver. So then the next thing is we remember the breast, then another GI structure, which is the pancreas. They all go to the liver. And the metastasis on the liver is usually widespread. Then the next one, the lungs. So we said colon and breast also is just like liver. They go to the lung too. Then we said the lung is paired. So the third one that will go to the lung is a paired organ, like the kidneys. And the last one, the brain. Most common for the brain, lung cancer. Second, breast. Third, melanoma. And that's preference for the gray-white region. So I think we are going to start from oncogene the next time. So in 2 lectures, we should be done with pathology. In 2 lectures. In 2 meetings. 1, 2, 3, 4, 5, 6. Yeah. So in 2 meetings, you are done with pathology. So do you have any question? Any question? This is what we have done so far. Any question, anybody? Okay. Dr. Precious, are you there? Dr. Precious,
Dr. Bali.
are you there?
Dr. Bali, I'm here. Can you hear me?
So do you remember the function of CTLA4?
I have gone in the spirits and the soul and the body. But I slept off.
You have slept.
So please pardon me. I'll go over everything again.
Okay. Dr. Adu, are you there?
Yes.
Dr. Adu, do you remember the function of CTLA4?
Hello, can you hear me?
Yes, I can hear you. I said, do you remember the function of CTLA4?
Hello.
Can I say it?
Is that Dr. Paulette?
Hello.
Yes.
So Dr. Paulette, you remember? Dr. Adu, do you remember it? Maybe Dr. Adu is on call. Okay, Dr. Paulette, you can tell us.
It stops T cells from being active. Let me put it that way.
Yes.
Yeah.
So it stops the T cells from being active. So that means that we can. So how can we use that clinically to our benefit?
By giving antibodies, I guess.
Yeah. So what would the antibody do?
It will keep the T cells active.
Okay, so that they can.
So they can kill the tumor cells, the lymphatic
Yes.
cells.
So that they can kill the tumor cells. So all these things are actually due to the fact that we want to attack the tumor cells. So if there's a CTLA somewhere that is inhibiting those T cells, and we know that it is T cell that can eliminate tumor cell, why not give antibody that will neutralize the CTLA4 so that the tumor cell, so that the T cells will be constitutionally activated and they can eradicate the tumor cells. That is it. So I know that we need time to consolidate all those things.
Hi, Dr. Babali. Please, what's the page in first aid of this pathology section?
The page that will stop, Abby.
Yes, yes.
This is page 219.
219. All right.
Yeah.
Thank you. Well
Right.
done. Thank you very much.
So we are going to call it a day and we'll continue tomorrow by God's grace.
Thank you.
All right. Bye bye, everybody.